The design and management of America's healthcare has been a politically charged issue for more than 2 decades. Discussions about it have remained contentious and mostly unproductive because it's really hard to deal with. It's hard to deal with because it's so personal, because the costs are huge and affect everyone's budget, and because the decision-making process is more political than analytical. And for all of those reasons, the Concerned Actuary Group believes that we have to start by addressing the fact that the decision-making process is not as well informed as it should be and can be. More specifically, we know that the country has the ability to make better decisions about healthcare, and we want to engage citizens, organizations, experts, and policymakers in a call for a new and better conversation about improving the healthcare policy decision-making process. As professionals who specialize in understanding risk and the costs associated with it, actuaries can and should play an important role in developing a broader, more informed decision-making process. The Concerned Actuary Group is a 501c3 organization established to improve public understanding of the importance of making sure all of America's social insurance programs are well managed and financially sustainable. Our specific areas of concern with regard to healthcare include public access to affordable, quality healthcare, the financial threat the current health system represents to the economy at large, the capacity of state and local government to pay for other public services, and the impact of all of that on the average household budget. Persuaded that the current decision-making process needed an analytical capacity more sensitive to the totality and complexity of the system, the Concerned Actuary Group spent the past 2 years developing a computer actuarial assessment model, the CA2M, that has that capacity. We believe the CA2M is a game changer, a powerful new tool that can help elected officials and policymakers make better decisions and give citizens more insight into how proposed changes affect them. The CA2M is a matrix-based model. It identifies and contains information related to activity, stimulation, and stress in 6 market impact signal areas, including cost, coverage, access, health status, economy, and sustainability. It also identifies and contains information related to activity, stimulation, and stress in the existing 8 coverage delivery mechanisms, including large group, small group, individual, Medicaid acute, Medicaid disabled, uninsured, Medicare, and other. Cross-referencing the market signals against the coverage delivery channels produces 48 analytical intersections that vastly enhance the ability to identify and understand the potential impact of proposed changes to the healthcare system. In each of those analytical intersections, users can access 3 different levels of information, including a summary overview highlighting key findings, a more detailed look at the data and key assumptions, and access to a document that contains all of the previous data and information, along with more detail on methodology, including the algorithms utilized in the assessment. The Concerned Actuary Group has recently completed a beta test of the CA2M that we think underscores both the value of enhanced analytical capacity and the ability of the CA2M to generate critical, timely, relevant, and accurate information to citizens and the healthcare policy decision makers. The CA2M beta test focused on determining what sort of information the model might have provided healthcare policy decision makers had it been available to them when they were assessing the Affordable Care Act, that is the ACA, as enacted in 2008. Please note that in order to do so, the CA2M beta test was conducted utilizing only data that was available at that time in 2008. You will note that the CA2M surface report highlights a graduated from 0 to 10 composite positive or negative impact for each of the 48 intersections. It also provides a compound impact for each of the 6 market signal areas. Our goal today is not to show you everything the CA2M can and has done in all of those 48 intersections, but rather to give you a sense of what it can do. To that end, let's take a look at some of the findings from the coverage market signal area. And let's start there by looking at how the CA2M categorizes coverage based on out-of-pocket costs related to income after subsidies. As you can see, the CA2M identifies an acceptable out-of-pocket percentage of income for 17 levels of income from $0 to $126,317 and an 18th percentage for those making more than $126,317. The CA2M then categorizes coverage as adequate if the estimated out-of-pocket costs are within the acceptable range identified in the highlighted column. Coverage is characterized as inadequate if the out-of-pocket costs are higher than the highest number identified in the range. So, for example, if someone making between $74,103 and $81,512 has coverage under which his or her out-of-pocket costs exceeded 10% of their income, the CA2M would identify that coverage as inadequate. Conversely, if the estimated out-of-pocket costs are less than the lowest number identified in the range, 6% of income for our $75,000 to $81,500 range, the CA2M would identify that coverage as disproportionate or excessive. With all of that in mind, note that the CA2M estimates that the compound impact of the ACA on coverage would be positive. Note also, however, that the degree of impact varies by coverage group both in significance and direction of impact. Let's start with the CA2M projected ACA impact on large group coverage. Assuming that at least one goal of the proposed ACA legislation is to increase the number of people with adequate health care coverage, CA2M projects that the proposed legislation would generate an increase, albeit modest, in the number of people with adequate coverage. Note that the increase is driven by people with low incomes obtaining adequate coverage by enrolling in exchanges or Medicaid, and by people with disproportionate coverage moving or being moved to adequate coverage as a result of increased cost sharing. A similarly modest positive finding occurs in the individual coverage market, where shifts to the exchanges improve coverage for those with inadequate coverage and increases in cost sharing move those with disproportionate coverage to adequate coverage. A significantly more positive rating of +8 occurs in the uninsured market, primarily because all of these people started out with inadequate coverage. So far, that's a positive compound impact of 11 points for the ACA on coverage. But the actual compound impact score is only 4 positive points, which means that the proposed ACA legislation affected people covered by Medicaid acute coverage in a negative manner. It did not increase inadequate coverage and actually had minor positive impact on the number of people with adequate coverage. But the proposal is projected to produce a significant increase in the number of people with disproportionate coverage. If we dig a bit deeper in the data and assumptions, we can revisit the income data and the relevant assumptions over again, and in so doing, discover that while the CA2M projects no significant change in adequate coverage, it does project a 19% decline in inadequate coverage and a 19% increase in disproportionate coverage. Interestingly, the CA2M analysis indicates little change between coverage percentages between 2008 and 2017 without the ACA. The data, assumptions, and the methodology and algorithms used to generate the key findings are all available in the 150 plus pages of the CA2M documentation guide. Obviously, the value of the CA2M is directly related to its capacity to produce timely, relevant, and useful information for decision makers and the constituencies they represent. Central to that goal is the ability of the CA2M to produce projections that over time consistently proved to be within a reasonable range of accuracy. In the ACA beta test, the key CA2M demographic and fiscal factors passed this test. For example, between 2008 and 2017, the population grew from about 304 million to 317 million. Using only data available in 2008, the CA2M ACA projections allocated the populations across the 8 coverage markets, and those allocations reasonably matched the actual estimates made by a variety of sources in 2017. Similarly, the CA2M projections of total 2017 costs of healthcare, again using only data available in 2008, reasonably matched the actual cost estimated in 2017. The key analyses of coverage for the 8 groups also meet this test. CA2M Medicare cost projections for 2017 with ACA, for example, came within 1% of the actual 2017 costs. Similarly, CA2M Medicaid cost projections for 2017 with ACA came within 1.5% of the actual 2017 costs. And CA2M out-of-pocket cost projections for 2017 with ACA fell within 2% of the actual 2017 costs. It should also be noted that other key projections also fall well within a reasonable range of accuracy. So, for example, the adequacy of coverage projections come within X% of the actual 2017 numbers, and when the CA2M projected changes in benefit utilization related to ACA by market group measured against a base of 1, the largest deviation from the actual 2017 numbers was less than 2%. Finally, we would point out that the CA2M ACA beta test projections, made using only data available in 2008, could have provided policy decision-making providers, insurers, and citizens critical information on some of the key questions of the day. So, for example, if we ask, how would this proposal affect the relationship between governmental healthcare costs and the net total of all governmental deficits, we would start by noting that in 1992, total government deficits came to $224 billion, of which about 7% or $16 billion was attributable to healthcare costs. We would also note that by 2008, just 16 years later, healthcare cost-driven deficits accounted for nearly half of all governmental deficits. And we could then point out that by 2017, only 9 years after that, actual healthcare cost-driven deficits exceeded the cost of all governmental deficits. And finally, the CA2M beta test also indicates that the CA2M could have flagged the likelihood of higher premium costs in 2008 while the legislation was being considered. There was no CBO estimate in 2008 of how the ACA might affect premium increases in the private markets, but an estimate was provided in 2010. That CBO estimate turned out to be optimistic, particularly with regard to the individual market. The CA2M also underestimated the 61% increase in that market by 2017, but it seems fair to hope that had the CA2M been in use at that time, a credible estimate of large increases in individual premiums within a less than 10-year period of time would have led to different discussions and better outcomes. Thank you.